A young patient was a bright 21-year-old university student with her whole life ahead of her. One day, a sudden excruciating pain led to a diagnosis: ruptured appendix. She needed emergency surgery. In the pre-op room, the anesthesiologist reassured her, "You'll sleep through it all." The young patient trusted them, closed her eyes, and felt the anesthetic enter her veins. But something went wrong. Instead of deep sleep, the young patient drifted into a nightmare. She became aware. She heard the clink of instruments, the surgeons' voices, and felt the scalpel's searing pain. Paralyzed by muscle relaxants, she couldn't move or scream. Her mind screamed for help, but her body betrayed her. She tried to make her heart race, hoping the monitors would alert the team, but nothing changed. She was trapped, fully conscious, enduring every moment of agony. The psychological scars ran deeper than the physical ones. The operating theater, once a place of healing, became a chamber of horror in her memory. Waking up in recovery was not relief, but the start of a long, painful journey. The young patient survived, but a part of her spirit was broken. Her story is a stark reminder. Intraoperative awareness is a rare but devastating complication. Behind every draped patient is a conscious mind we must protect. For the young patient and for every patient, the promise of anesthesia is sacred. When that promise is broken, the consequences can last a lifetime. This is why vigilance in anesthesia is not just technical, it's a moral duty. We must never forget the person beneath the drapes. Intraoperative awareness is when a patient becomes conscious during surgery under general anesthesia. Imagine hearing, feeling, and understanding everything happening around you, unable to move or speak. Your body is paralyzed, but your mind is wide awake. This is not a dream or a vague memory. It's explicit recall, clear, vivid, and often traumatic. The promise of anesthesia is unconsciousness and freedom from pain. When awareness occurs, that promise is shattered. The psychological trauma can be immense: nightmares, anxiety, even PTSD. General anesthesia is not just sleep. It's a delicate balance of drugs, hypnotics for unconsciousness, analgesics for pain, and muscle relaxants for paralysis. Awareness happens when this balance is lost. Usually, not enough hypnotic, but enough muscle relaxant to keep the body still. From the outside, the patient looks asleep. Inside, they're awake and suffering. The impact goes far beyond the operating room, breaking trust and leaving lasting scars. Preventing awareness is not just a technical challenge, it's an ethical responsibility. Every patient deserves the protection of their mind as much as their body. Intraoperative awareness is rare, but not rare enough. Globally, it affects 1-2 in every 1,000 general anesthetics. With millions of surgeries each year, that's thousands of patients worldwide. In India, the risk may be slightly higher due to emergency surgeries and resource limitations. High-risk surgeries, trauma, cardiac, emergency cesareans, carry a much greater chance of awareness, sometimes as high as 1 in 100. For routine, low-risk surgeries, the risk drops to about 1 in 15,000. These numbers aren't just statistics. They're real people enduring real trauma. Advances in anesthesia have made surgery safer, but our work isn't done. We must keep refining our techniques and monitoring to drive these numbers as close to zero as possible. Every case of awareness is one too many. Intraoperative awareness isn't random, it's the result of specific risk factors. Emergency surgeries are high-risk, unstable patients can't tolerate standard anesthetic doses. Anesthesiologists must balance keeping the patient alive with keeping them unconscious. Sometimes the dose isn't enough. Muscle relaxants, essential for many surgeries, can mask all signs of awareness. A paralyzed patient can't move or signal distress. Some patients are naturally resistant to anesthetics or have built up tolerance from chronic substance use. Equipment failures, like a faulty vaporizer or IV line, can lead to accidental underdosing. The convergence of these factors creates the dangerous window for awareness. Recognizing and managing these risks is critical. Vigilance and preparation are our best defenses. High-risk surgeries push anesthesiologists to their limits. In cardiac surgery, anesthetic needs drop when the body is cooled, but rise rapidly as the patient is rewarmed. Mistiming can open a window for awareness. Emergency cesareans require lighter anesthesia to protect the baby, increasing risk for the mother during the most intense moments. Trauma patients with low blood pressure can't tolerate normal anesthetic doses. Life-saving takes priority, but awareness risk rises. The anesthesiologist must constantly weigh the risk of awareness against the risk of collapse or death. These are calculated risks, not negligence. The pressure is immense, and the margin for error is slim. That's why anesthesiologists need the best tools, training, and support. Protecting both body and mind is the ultimate challenge. Technology like the bispectral index, BIS monitor offers new hope. BIS uses a forehead sensor to measure brain activity, giving a score from 0, no activity, to 100, fully awake. The target for deep anesthesia is 40-60. If the BIS rises, the anesthesiologist can intervene before the patient becomes aware. But BIS isn't perfect. Electrical interference and certain drugs can give misleading readings. It's a valuable tool, but not a foolproof detector. Clinical judgment and vigilance remain essential. The best approach is multimodal. Use BIS as an adjunct, but also monitor vital signs and surgical stimulation. Technology helps, but it can't replace the experienced human mind at the head of the table. Ultimately, it's the anesthesiologist's skill and attention that protect the patient. Preventing awareness requires a systematic, vigilant approach. Think of it as a safety checklist, like pilots before takeoff. First, check all equipment, anesthesia machine, vaporizers, IV lines, monitors. Second, identify high-risk patients, history of awareness, substance use, or conditions needing lighter anesthesia. For these, consider brain monitoring like BIS. Third, use a multimodal approach. Combine different anesthetic agents and monitor all vital signs, not just BIS. Fourth, always confirm unconsciousness before giving muscle relaxants. Never paralyze a patient who isn't fully under. Maintain constant vigilance, avoid distractions, communicate openly with the surgical team. If lighter anesthesia is needed, coordinate with the surgeon to pause during the most stimulating parts. This teamwork is essential. Embedding these practices creates a powerful shield of prevention. Patient safety is a shared commitment. Even with the best precautions, awareness can still occur. Detecting it early is crucial for healing. The Brice Protocol, a simple 5-question interview, helps identify patients who may have experienced awareness. Ask, what's the last thing you remember before sleep? The first thing after waking? Anything in between? Any dreams? What was the worst part? These questions gently uncover hidden trauma. If awareness is suspected, respond with empathy and validation. Reassure the patient. This is a known rare complication. They are not imagining it. Offer immediate psychological support and counseling. Apologize sincerely and investigate the cause to prevent future cases. The Brice Protocol is more than a screening tool. It's a compassionate practice. It honors the patient's experience and starts the healing process. Every patient deserves to be heard and helped. In surgery, we focus on the body, but the mind matters just as much. Intraoperative awareness reminds us, every patient is a conscious, feeling human being. The terror of being awake during surgery can leave invisible scars that last a lifetime. Our duty extends beyond physical healing. It's about protecting the whole person. We must foster empathy and psychological safety in our operating rooms. Listen to patients' fears before surgery and for hidden trauma after. Anesthesia is not just turning off a switch. It's taking custody of a person's consciousness. This is a sacred trust, demanding vigilance, skill, and compassion. Let's use every tool and every ounce of humanity to prevent awareness. Our true success is measured not just in lives saved, but in minds protected and trust upheld. Protecting the unconscious mind is a responsibility we must never take lightly.